So thank you, Madeleine, for the invitation. I'm very glad to be with all of you. So I'll talk about the cardiovascular imaging portion of the SHACS, which is led by Madeleine Durand, initiated initially by Cécile Tremblay. I have no disclosures. I have some acknowledgement also at the end of my speak. So HIV infection is associated with an increased risk of cardiovascular disease. Causes that are discussed, of course, is the increased survival of people living with HIV. In the more recent years, the increased prevalence of cardiovascular risk factors in the HIV population, mechanisms such as chronic inflammation has been discussed, and there's probably also an impact of antiretroviral therapy. From the Danish HIV cohort study, we see here survival curves showing the important improvement in survival in the HIV population since the introduction of antiretroviral therapies. However, even if it's not yet reaching the survival of the general population. What are the arguments for the increased risk of myocardial infarction, MI, in people living with HIV? There's a first study here which showed a moderate increase in the rate of MI, myocardial infarction, in people living with HIV after adjustment for cardiovascular risk factors. Other studies also showed similar results, and one of them is a study performed in the Province de Québec by Madeleine Durand, Cécile Tremblay, and co-workers, which showed an adjusted relative risk of 2.1 of myocardial infarction in people living with HIV. This is all about HIV-associated coronary disease at its clinical stage. What we need next to do is to investigate factors related to the preclinical stages of HIV-associated coronary disease, such as what is the burden of subclinical atherosclerosis, subclinical in the HIV population, what mechanisms are involved, and early cardiovascular intervention strategies that could be tested. How to assess subclinical coronary disease as part of an HIV cohort study. In the SHACS, in the Canadian HIV and Aging Cohort study, we use cardiac CT for the assessment of subclinical coronary disease. Computed tomography is well suited for the non-invasive imaging of coronary arteries in asymptomatic individuals, especially when we are in a research setting. There are various CT markers using computed tomography for the assessment of subclinical atherosclerosis. First, we can use non-enhanced computed tomography, which will allow the detection and the quantification of the calcium component of the plaque, and calcium is white on CT scan. When we use contrast-enhanced computed tomography, coronary plaque can be classified into non-calcified, mixed, or calcified plaque. And finally, with advanced image post-processing tools, coronary plaque can be quantified according to its volume. So the general aims of coronary CT plaque imaging as part of the SHACS is first to compare the burden and characteristics of subclinical coronary plaque between people living with HIV and non-HIV controlled participants. This can be done as part of a cross-sectional CT study and later with a follow-up CT study. A second objective or aim of coronary CT plaque imaging inside the SHACS is to implement prospective imaging database, which is already available for correlative studies with other markers, such as inflammatory markers, fat, or frailty markers. In the next few slides, I will present recently published data coming from a cross-sectional CT study, which was nested in the shacks. But first, a few words about the shacks, which is the Canadian HIV and aging cohort study. It is led by Madeleine Durand in Montreal. The shacks involves more than 1,000 participants, 12 centers in Canada, a blood and cell biobank, database already available for researchers. In the shacks, there are 3 platforms of cardiovascular imaging. First of all, the cardiac CT platform, then the carotid imaging platform, and also a work in progress for vascular PET. And finally, all the lab teams working as part of the shacks. So about this coronary CT sub-study nested in the shacks, we did prospective recruitment of shacks participants, HIV participants, non-HIV participants without known coronary artery disease with calculated low to intermediate cardiovascular risk. All participants underwent cardiac CT and image assessors were blinded to the HIV status. In this sub-study, 265 participants were included. Mean age and cardiovascular risk score was similar between the HIV and the non-HIV groups. In the HIV group, there were more smokers and more participants under statin. Also, in both groups, there were more males than females. Among the HIV participants, 92% were on ART. So for our main results, if we talk about the prevalence of our CT markers, the overall prevalence of coronary plaque was similar between the HIV group and the non-HIV group. When we stratified coronary plaque according to their subtype, non-calcified plaque was more prevalent in the HIV group. Now, for the volume of the CT marker that we can measure, the overall plaque volume was similar between the HIV and the non-HIV groups. And again, however, the non-calcified plaque volume was increased in the HIV group. What is the general significance of non-calcified plaque as can be found on CT? In general, the extent of non-calcified plaque from CT study that had been performed in non-HIV participants will predict higher cardiovascular event rates. For example, in this study in non-HIV individuals, which were followed for years after cardiac CT, the survival rate decreased in patients with non-calcified plaque compared to calcified plaque. This is another study in which the amount of non-calcified plaque on CT predicted coronary events in non-HIV individuals, but this was not the case for calcified plaque. It's worth mentioning, however, that in the confirmed CT registered, calcified plaque did not show a significant correlation with mortality. So the conclusion of this specific cardiac CT study, and this will be my final slide, is that asymptomatic HIV individuals under ART have more non-calcified plaques in comparison to non-HIV individuals after adjustment for cardiovascular risk factors. In general, non-calcified plaque is considered more vulnerable. Thus, our findings may suggest one anatomic substrate for the increased risk of myocardial infarction in the HIV population. Thank you.